So I'm Anthony Harries, and I'm going to briefly describe for you some examples of running operational research in Malawi in both tuberculosis and HIV care. For those of you who don't know where Malawi is, here it is in central southern Africa, and I worked in that country from 1986 to 2008, a 22-year period. This is a bit dated, this slide, but it gives you an idea of where Malawi stands in relation to, example, America. So a population of 16 million, very poor, as you can see, very little money available for health care, very few doctors, very few nurses, and a life expectancy that is way down compared with European and North American countries. Now, Malawi, despite these problems, had a very good tuberculosis control program. This great man on the right is Dr. Carol Stiblow, who basically initiated what we now know as the DOTS tuberculosis control in Malawi way back in the late 1970s and early 1980s. So this was a countrywide control program. We had standardized case finding, we had good treatment and monitoring systems, regular structured district supervision, so we knew that our data was good, accurate record keeping, and when we kicked off in the early 1980s, we had about 4,000 TB cases per annum with a cure rate in smear-positive pulmonary TB patients of about 90%. Unfortunately, in 1985, we got hit by HIV/AIDS. So this shows you within 10 years the rapid escalation of HIV in the adult population. In 1995, reaching 14% of adults, 1 in 7 adults in that country had HIV. And this did bad things to tuberculosis control. Firstly, our TB case notifications rose by a factor of 500%. Our TB case fatality rose from 5% to way over 20%, and we began to see a lot of recurrent tuberculosis. So we became acutely aware, and so did the international community, that DOTS tuberculosis control on its own was insufficient to manage HIV-associated tuberculosis. So from 1996 to 2004, it was decided by the government and by donors that supported the government to bring operational research into the National Tuberculosis Control Program. So we had a definition of operational research which has survived to this day, and in fact is used by Ronnie Zachariah in a very good publication in the Lancet Infectious Diseases. But essentially it is a search for knowledge on strategies, interventions, and tools which can improve program performance and healthcare delivery. There are some guiding principles. First of all, we define the program objectives. Secondly, we identify constraints or challenges to meeting those objectives. And finally, we ask research questions around those constraints. That is really what operational research is about. The methodology is very simple. These tend to be descriptive or cross-sectional studies. Occasionally we use case control studies. We also use cohort studies, which are either prospective or retrospective in nature. And the important thing is that the research is carried out within the routine system and reflects real life. There's a real synergy between the data monitoring systems in the routine health care and operational research. So here you can see in the TB control program, we used the data in the treatment cards and in the registers to basically get our data for operational research. Because we wanted that data to be good quality, the data in the monitoring systems became better. So this becomes a win-win situation. By embedding operational research into the program, your data collection routinely improves. That's good for the program, and it's good, of course, for operational research. So how did this work? Well, first of all, we put a central unit officer into the central unit of the TB control program, and this officer was responsible for research. Initially, that person, in fact, was me. And when I trained a Malawian up, and after I left the National TB Programme, that officer who was trained up took over from me. Some key principles. That officer sat and sits on all NTP management committees, understands how TB control works, has to be competent at research, and it should not be the program manager because that person is already too busy running a program. Secondly, importantly, the studies, the operational research studies, are planned within the National TB Programme. The whole thing is embedded in that NTP framework. Operational research is included in the national plans. There's a dedicated budget line for the research. And importantly, you need a good connection and collaboration with the National Health Science Research Ethics Committee. And we had that in Malawi. We had a very good structure, and this is how the structure worked. We had a Malawi TB program management group that met formally every 4 to 6 weeks. And in the morning, we discussed program issues, and in the afternoon, we discussed operational research. So who sat round that table? Well, first of all, the Malawi NTP chaired that meeting and sat round the table. But we were supported by people from Malawi institutions, the medical school, non-governmental organizations, for example, MSF, and the National AIDS Programme. And whenever they were in country, we also had international expertise from WHO, from the Union, and from various schools of tropical medicine in England and in Europe. So basically, research ideas put on the table, we discussed those, decided what was good for TB control, and then, as I said, every 4 to 6 weeks, we would see, are those research ideas moving forward? Who is implementing the research, and what is happening to that research when it has been completed? You, of course, need a few resources, so we need a small office, we needed a computer, transport, stationery. We paid some research allowances for district TB officers doing work outside of their routine. And importantly, we strongly believed in disseminating that research around the country. Today, we would probably do that on the internet and by using electronic software. But going back to 1996, that was not available. So what we did was every year put our research publications together. We printed, say, 500 copies of these research and review studies, and we disseminated them around the country during our quarterly supervisions. We also engaged in training. So we trained people during supervision. We encouraged TB officers to develop their own studies. We ran a research training workshop where, in fact, one of the people who used to work in Malawi, who became a medical editor in Canada, would come out at his own expense every year and teach us, essentially, how to do research and also how to write the research up in this writing skills workshop. And finally, and very importantly, and welcomed by everybody, we had an annual review meeting where people could present the results of their research to a national and then increasingly an international audience. I think we were very good at moving fast and making decisions. So research data would be entered as studies progressed. We would rapidly complete the analysis and the writing up of that research into reports and papers. And because we were part of government, part of a national program, we could act on those research papers, those reports, and make appropriate policy and practice decisions. And finally, we had to report annually to the Ministry of Health and to our donors about research outputs. And I think our template was quite good. Every year we would say these were the studies, activities planned, this was what was implemented, this was what was completed, this is the paper or the papers that have been published, has it influenced policy and practice, and has it, above all, improved our TB program performance and, for example, reduced death rates in patients with TB on treatment. Let me give you some examples of what we did. So this slide shows you on the left of the picture important operational research that we did nationally. We changed TB treatment regimens in relation to the HIV epidemic. We decentralized treatment out of hospitals into the community because our hospitals were filling up with too many TB patients. We looked at patients who transferred out from one facility to another. We looked at HIV testing and cotrimoxazole preventive therapy, CPT. We got involved in the prisons. We got involved in recurrent tuberculosis. We worked with traditional healers. And a lot of our work, in fact, had an impact because we wrote it up and published it at the international level. And I think we influenced thinking about how to improve tuberculosis safety for healthcare workers, prison TB control, and so on. Let me give you 3 examples. We worked with traditional healers, and we found out through our research that for nearly half the patients with infectious tuberculosis, the first point of call was a traditional healer. And this, of course, delayed things. People stayed with traditional healers for a month, getting worse usually, spreading the disease in the community, and also getting individually worse with disease progression. So this led, in fact, to important practice changes. We got money to then train traditional healers, 5,000 between 1998 and 2000, to ensure that they tried to refer patients with tuberculosis earlier to the TB control program. We looked at patients who transfer out. So what happens in a country like Malawi is you start treatment in facility A, and after a few months, your job or whatever may move you to another part of the country and you continue treatment in facility B. So in the TB program, we recognize this. So we have what's called transfer outs, which are recorded in the TB register. And then if somebody then moves to another facility, they become what's called a transfer in. So of course, transfer outs and transfer ins should balance. And we decided to look at this. We thought it worked well, but to our shock and horror, it worked very badly. So for example, we found out in 1999, we had 2,586 transfer out patients in the TB register, but only 1,300 were recorded in the transfer in register. Nearly 1,200 went missing somewhere. Of those patients in both the transfer out and the transfer in register, only 694 had matched names. And of those with matched names, only 373 had the same outcome. This clearly was not working at the program level. And this resulted in a big change in our program. We improved our forms, we improved the supervision of health centers, and we ensured that transfer out and transfer in became a big issue, a big thing to talk about during the regional district TB officer meetings. And finally, we looked at a package of HIV testing and cotrimoxazole prophylaxis in 2 districts in Malawi, believing that this package might reduce case fatality. I'm going to cut this story short and just to say that we did find in both these districts the package was associated with a reduction in case fatality from 36% to 28%. High still, but nevertheless reduced. And the ministry, the government, made a policy decision that HIV testing and cotrimoxazole be given to all TB patients in the country in a phased approach. So what happened? You can see that over 8 years, gradually, the proportion of TB patients nationally being HIV tested increased from 26% to over 90%. You can see that of those HIV positive, most of them received cotrimoxazole, CPT, and you can see that from 2004 onwards, we gradually began to introduce antiretroviral treatment into the program as well. Did it make a difference? Yes, it did. You can see our treatment success increased over these 8 years from 71% to 88%. Death came down from 19% to 8%, and other adverse outcomes similarly decreased. So between 1996 and 2004, in the National TB Programme, we had about 130 published papers. We also wrote this WHO monograph on operational research in Malawi, and we became quite well known globally, and we presented at international meetings about embedding operational research at a disease program level. Now, it didn't always work fine. We had problems. We had too few skilled research officers and too much burden of work imposed on them. There was also sometimes a lack of understanding at the district level about the need for high-quality data, particularly if you want to publish this data. And some projects failed. They failed because of poor supervision. They failed because of data manipulation, which was identified, and we had to therefore scratch that project out, stop it. Sometimes the research question was too complicated, and sometimes we did things that had no influence whatever on policy and practice. That is real life. You cannot expect always to have 100% success. Now quickly, let me just spend 5 minutes or so telling you about antiretroviral treatment in the country. I was involved in this from 2004 to 2008. We had a very simple way of scaling up based very much on the TB Control DOTS system. Free treatment to eligible patients, one first-line regimen only, one second-line regimen only, a standardized system of monitoring and reporting, quarterly cohort analysis, and quarterly structured supervision. And just like the TB program, we had a very strong focus on monitoring, evaluation, and supervision, essentially ensuring that the data that we collected was as accurate as possible. Malawi did very well with ART scale-up, and this shows you over a 9-year period going from virtually nobody on antiretroviral treatment to nearly 450,000 people alive, retained on treatment, who would otherwise be dead if it was not for this life-saving therapy. Now, in 2006, we were busy scaling up, but an anonymous donor came along and said, I'll give you a small amount of money for operational research that hopefully will improve the way your program is delivered. And we embarked on a number of projects, and I will just give you a snippet of 3 of those projects. We looked at healthcare workers. This was an important, contentious issue at the time because the government said, you're expanding antiretroviral treatment, you're pulling healthcare workers out of the system, you're depleting the health system from healthcare workers because of running antiretroviral treatment. Our belief was that many of those healthcare workers in fact had HIV, and antiretroviral treatment was in fact saving their lives as well as other patients' lives. So you can see here that over a 4-year period, the number of health workers on antiretroviral treatment increased from 38 to 2,398, and we could follow their survival based on our routine records. And you can see that they had a survival of 80% almost at 18 months. We were able to calculate that the number of healthcare worker lives saved balanced those that we were taking out of the health system to run the ART clinics. A balanced situation. The Malawi Defence Force had a problem with HIV. So here, very simple operational research looking at the number of soldiers started on ART. You can see that line going upwards. And then the army also ran a confidential register on the number of soldiers each year dying from whatever cause. And we looked at this over 5 years. So you can see that in the early years, 2002, 2003, 2004, where we hadn't really scaled up ART, about 120 to 150 soldiers died each year. Within 2 years of ART scale-up, those deaths came down to 30 per annum. This really impressed the Commander-in-Chief of Malawi's Armed Forces. We presented this data to him, and in fact persuaded him to invest his own defence money in setting up ART clinics for the army around the country. And finally, we were interested whether at a rural population level, the scale-up of ART made a difference to population mortality. And we set up a very simple study looking at deaths recorded in village registers. This is an old system that has been going on for many years in Malawi, where village headmen record who is born and who dies in a village. We looked at the sales of coffins, because people basically who die in Malawi are buried in coffins, and we looked at church funerals. I haven't got time to go into this in detail, but you can see here in that top figure that according to village registers, those registered deaths over a 7-year period in the traditional authorities decreased from nearly 11 per thousand down to about 7.5 per thousand. You can see on the left that registered church funerals went down, and you can see that coffin sales virtually dried up. In fact, coffin makers had to go and find additional alternative employment. So in conclusion, what I'd like to say about operational research is that this can be embedded with political will into a disease control program. I think it's very important that one has a framework, though, to see whether, in fact, one is doing operational research and one is making a difference. And I think this framework shown here is really quite useful. And it goes like this. How many studies have been approved? How many have been completed? How many papers have been written and submitted to journals? How many have been published, i.e. it's a quality control paper, it will not be published unless it is good? Have those research findings been disseminated in country and internationally? Has there been a change in policy and practice? And above all, has program performance improved, and has this impacted on lives of people affected by tuberculosis or affected by HIV/AIDS? Thank you very much.